We have roughly about 25 minutes for discussion, questions. Before I take questions from the floor, could I ask the panelists if they want to ask questions of each other? Curveball. If not, we could take questions from the floor. Can we?
I have one.
Oh, okay.
For you. So I know it's all preliminary, but I'm really interested in the mHealth versus community. I really like that you guys included that because we often don't. Maybe because we always want to believe that the techie approach is the best approach. So the numbers looked really close, but like even qualitatively, can you give a little insight into what? Oh, I'm supposed to be using this. Can you give a little insight into what differences you saw and which seems to have had a greater impact?
Yeah, I'll borrow that, thank you. We, as you said, were keen to include both. We were mindful that the medium's not the message, so we thought it would be very useful to have a community participatory intervention as well as the mHealth intervention. We did find qualitatively that results were very encouraging in terms of the motivational impact of both interventions. So it wouldn't have been a surprise had, for example, the community-supported approach had a greater result on appropriate treatment than the technology-supported approach. I mean, I guess it's a fairly close-run thing, as you said, in that data, but certainly qualitatively we found that they were both very motivating in slightly different ways. I think one of the big constraints that community health workers reported was not feeling respected locally. And so I think the community participatory intervention, the village health clubs really turned that on its head. There was a greater local understanding of what the community health worker program was all about and really the value that it brought. On the other hand, the technology approach really results in a greater sense of connectedness to the health program, which was very big for our community health workers. So you're sort of comparing two slightly different impacts, which were equally motivating, I think, for the workers. So, like I said, we wouldn't have been surprised if the reverse was true.
Very interesting. Is there anybody on the panel that wants to ask a question of? If not, we'll turn to the floor. Let's see. You had the first question.
Hi, yes. I'm not sure who to address this to. It could be to all three, not Sandeep. You'll hear why when I ask the question. I was just wondering how much training health workers required to use the apps and smartphone technology.
Who would like to take that?
I can.
Yes, please.
I think it's an interesting question, and I also think it's relevant when we're talking about which technologies to use, because you will talk to people who hate on smartphones because they're too high tech, and you'll talk to people who hate on dumb phones because that's in the past, and smartphones are getting cheaper and cheaper, and they can do so much more, then why wouldn't we embrace that? And for us, I think there's an initial learning curve that's higher for smartphones, but once you get past it, so that could mean adding a day, and a day onto a training. For our Zanzibar program, we would do a day refresher for just health with no technology at all, and then 3 days on the phones. And I'm not sure how long the Malawi training was, but I think it may have been slightly longer than that. But I don't think any more than a few days regardless. And often once they get through on the smartphone, the swiping can be difficult. Like if you've not used that device before, we have an e-partogram project and it's the same thing. But once you get kind of past just the basic functionalities, the functionality of the application itself is not that much more to learn.
How about any other responses to that query?
Yeah, similar. I'd say for us, I'm sorry.
That's fine.
It's similar in that it was a few days to a week, I think, of training. We did have there's a Java-enabled Nokia in Uganda and a simple Samsung Galaxy smartphone in Mozambique. The differences between how the training was received on those, I'm not exactly sure. I'd have to throw to my colleague Karen to talk a little bit more. Miss Jackie, you can just give her a microphone. She's got to shed some light on that, I think.
Yeah, no, I think that's we have some quite interesting observations on that, because obviously using a Java-enabled phone is something most of the users were already used to, so it didn't take much training. We trained for about 3 days, I think. Whereas using smartphones, we had to spend about 4 days, but with a refresher training quite soon after, because they were simply not used to using Android phones. However, we've also found that once they had gone through the training, they felt very comfortable using them, because with the apps, putting the apps on the front screen, etc., and blocking all the apps that they didn't need it to use, made it fairly simple. I think what limited for both types of phones, the limiting factor was most of the time eyesight problems. We have a lot of community health workers who are slightly older and who don't have access to glasses, and we found that being almost the biggest challenge. It's having enough font size.
Yeah. Alice, did you have a?
I think it's not different. It takes a few days to a week, and more and more community health workers show interest with the new technology. And as she said, that it takes a little bit longer at the start, but because initially they had their own phones, but I think my colleagues on the floor will also be able to explain how long normally the training takes, because it doesn't take more than a week. But we do have refresher trainings on that, and the most important thing is the motivation to learn that really has enabled them to take up the phones for a shorter duration.
I'm going to ask a follow-up question of all of you on that. Do you have any mechanisms whereby after someone has a training, if they can't remember a specific thing or a function, or they're having difficulty with something, is there someone they can call for guidance? So beyond the training, a month later, 2 months later.
I think I'll direct that question to my colleague who was working directly with the community health workers on the floor, Simon.
Thank you. So what we did, we had 3 days of in-house training on how to use the smartphone, and of course how to use the tool within the smartphone. But out of the training, we were able to pick out for the 2 sites, individuals that we thought were faster in taking up the skills for using of the smartphone as well as the tool. So those people acted as the go-to points within those communities where they were. And also looking at their supervisors who had a previous experience with the use of smartphones, so it became easier for them to support at their community level. But in the event that there's a technical bit that wasn't quite easy for either that person or the supervisor to handle, then it will come to us, and then that will be able to support it.
Interesting. Next, this gentleman here.
Hello, my name is Monwar. I am a final year doctoral student in health communication in Singapore. So I found BBC Media Action research is very interesting, and it is quite close to my research. So I have a question to Mr. Sandeep. I noticed, in almost probably in all cases, exposed and unexposed, the number of participants were not equal. So do you think it has impact on the effect size, or what are the I mean, what are your comments on this? I mean,
no, it would not. The exposed was larger because there were different sets of questions. Like, let me give you an example. The study was called Usage and Engagement Study. So if you want to talk about things on, what was the last interaction like, and what questions were asked, and so on and so forth, then you had to talk to somebody who's had a relatively recent exposure. So we had people who had been exposed to mobile kunji at least once during the last 2 visits, which we call recently exposed. Then we had a group which might not have been exposed in the last 2 visits, but had been exposed to mobile kunji earlier, but could recall the event quite clearly. And the third set was exposed to those specific priority behaviors, right? I mean, you're going to talk to a currently pregnant woman on birth preparedness only if she has been exposed to birth preparedness messaging through mobile kunji. So that was ever. So because, there were 3 separate audiences on the exposed side, and the other side was just somebody who's never got exposed to mobile kunji, and hence the difference.
Yes, this woman in the middle of the gray.
Thank you. Thank you very much for very interesting presentations. My name is Hannah Clark and I'm from FIBA Radio. And this question's for Sandeep and Dan. You can choose who answers it. You both mentioned very briefly that the content of either the SMS messages or the audio was designed carefully using behavior change communication methodologies and techniques. And I'm assuming the content of these messages is just as important as the technology that's being used. And I just wondered whether the learning from that is also being captured in the studies you're producing so that we are developing the right messages as well as using the right technology.
Okay, this study is an evaluation study or an impact assessment study, but this research had to be done in the beginning. What happens usually, because health sector messaging is very important, you just can't go and give any message that you want. There is a committee which has been formed by BMGF, which has government health functionaries at a very senior level, which has got CARE, which is also one of the primary partners. It's got BBC and a whole lot of other people. The contents of the message is something which is signed off by the technical committee and endorsed by Government of India. Then comes a series of tests on how you package it and how you write down to language tests into what sort of local dialect will come into play, to what sort of examples that you will be using, and so on and so forth. So all that has been done quite exhaustively before we even actually rolled it out. So that's all done, that's all documented. This is just the results. Must have been fairly okay because we're getting results which we wanted, so.
Always a sign. Dan, do you have any follow-up for that?
Yeah, I mean, the content of the messages was a key concern for us. And firstly, we didn't want to disrupt the program by being overly descriptive or culturally inappropriate or too directive. So the content and the tone were absolutely critical. So really, we drew on some of the supervision literature, the actual content of the messages, and we wanted to reinforce some of the ideas that have been introduced in training. We wanted to give some reminders, but most of all we wanted to give a lot of encouragement and be overwhelmingly positive. And that was based on the formative research that we conducted. We don't have sign-off at, say, government level for the content, but we certainly have a process of development for the messages, and it is also documented within the project.
Maybe I could also direct that question to Alice, because her project I found particularly interesting in the fact that they're trying to do child development and deal with disability, whereas they identify children with disabilities, which is an even in some ways more complex issue to work through. So do you want to add anything to the kind of content?
I think the project, the content of disability was some of the good outcomes we have gotten from the project, because when the community health workers were trained to use the mobile phone to identify the child milestones, it is now from those particular households they were able to identify children with disability who were basically hidden. And that is now a way forward to see how best now we can take up these new findings, because it's really an area of importance.
Very interesting. The gentleman in black in the center back.
Thank you all for some very informative and exciting presentations of your collective work. One of the issues which has been raised a lot today is scalability. I just wanted to ask you all, whoever can respond, it doesn't matter. Was the issue of scalability something you identified at the outset of these projects, or is it something that is ever coming out of the work, or are these remaining as they are, sort of constrained projects in their own right? So is scalability something that factors into the prelim, or is it something that comes through the process of realizing a project and its success?
Anybody?
Okay. I can't speak for projects going around in the rest of the world, but at least from whatever little my interaction has been with the Bill and Melinda Gates Foundation work in India, that's the first question that's asked, and I think that's something which has been set in the log frame itself. And let's say for something like Mobile Kunji, let's see where is the expenditure. The expenditure is in training frontline health workers. The expenditure is in printing these cards, and the expenditure is in subsidizing the call cost, because this person will be making a call. Right now we give them a certain number of free minutes. All the major network providers give that minute, and that's subsidized through the Gates Foundation. Going forward, this is a project which is now being scaled up across 6 other states, and government is going to be subsidizing everything. It's going to pay for the call cost, all the training, all the printing. All the Gates Foundation is doing is putting up the national platform and the data center, which is part of their deal with the government in any case. And that was what was success, how the success was going to be measured, if this is a solution that's going to be taken up by government.
And anybody else want to respond to that question?
The concern about sustainability, I think it's always a concern of every project that is on pilot phase, and after the intervention has been successful, then what next? From AMREF perspective and all our partners, this project was a strong partnership with the Ministry of Health. So the community health workers who we are working with, we have direct link with the Ministry of Health at the community strategy level, even at national level. What we have shown so far is that this intervention has worked, and moving forward, AMREF has other interventions that are still within the mHealth platform, and we are seeing ways of really leveraging some of the best practices to ensure that we continue to have this program moving forward, its benefits being utilized. But I can't really say directly we are scaling it up, because now we don't have funding, but we have other projects within AMREF that can leverage the same, and the Ministry of Health is also interested and is talking to us on how best we can move forward on these practices.
I'll just say a quick, I think it's great that you asked that question. And I think it's a concern for everybody, especially with mHealth, because as we discussed earlier today, governments are often interested in innovation, but often either don't have the capacity or are worried about the capacity to carry it forward, both in terms of human resources and in terms of money. So I think it's an important discussion to have upfront, obviously, and how you define it is important as well. If you're working in a health system where 80% is funded by donors, does sustainability mean you get another donor to fund it for longer? So anyway, I think those definitions are important. The Zanzibar project, really, it took proving the concept in one phase, then it took scaling enough, and now it's taking, okay, but let's make it cost effective. So that's the first question that we get. I mean, we pay for transport. That's expensive, so beyond the technology. And so I think also there's innovation in that. And our next phase as we scale up further is getting more creative about how we pay for transport and thinking about savings wallet approaches with mobile money, and how can we empower women and families to save just a little bit, and working with our mobile companies who have interest in expanding mobile money, for example. It's in their interest to get more customers. And so how can we work with them to create this system? And that will be kind of in our next phase. So and the short answer would be do it up front to the extent possible, then keep trying, and you have more to go on once you prove that it works.
Very good. I'm conscious. Oh, did you? Yes, please.
Just be very brief, but just to add, perhaps because we're also funded by the Bill and Melinda Gates Foundation, it was front and centre from the start. The scalability of the program had to be there. In order to achieve that, we've got a large costing component of the project, so we can look at cost effectiveness. We work in conjunction with the Ministry of Health every step of the way, so to echo my colleagues' comments. And also at the back end of the project, we've got a large focus on advocacy and sharing the results to show whether we have been effective, at what cost, to generate funding for scaling up.
Very good. I'm conscious of the time. Maybe two more questions. There's the woman up there.
I have a question for Sandeep Ghosh, I think. It's a very interesting project, I thought. One thing what I would like to know is, you said that the difference between the exposed and unexposed group, it was quite significant. I'm sure it is significant. But how significant was it? I mean, by looking at the percentage, it's just difference of 1 or 1.5% difference between two groups. So which is that really statistically significant enough? Or
Yeah, I don't know whether it was 1.5, but if you see the stars, I don't know whether we can go up. Right. Single star, it's significant at 10%. Double star, it's significant at 5%.
All right, okay.
And triple star is significant at 1%. Most of the cases, it had 3 stars, so it was...
So you have set the significance level at, you have
That's
certain...
right.
Okay, right, thank you.
Okay. Why don't this gentleman down here in the blue sweater? We're making him work here.
I'm David Deakin from Tear Fund. We've done work in 4 African countries on mHealth in maternal and child health. And we're now looking for scaling up and just looking for quite big funding. And I noticed several of you mentioned the Gates Fund as a sort of key donor in your programs. So this is really a rather general question, but is Gates still the main funder of mHealth, or are you aware of other donors that we should all be thinking about?
Our panelists will write you a check. What would you like to respond? There are a number of places that now fund mHealth.
Yeah, and I bet there are people from the audience as well who could answer that question. Our first phase of the Zanzibar, first 2 phases rather, were Gates funded Gates Grand Challenges. And the next phase will be Saving Lives at Birth, which is a consortium and actually run through USAID. And I know USAID has their DIV initiative is all about innovation. I think others.
Okay. The other?
I think that's a difficult question to answer because our project, the pilot phase, is funded by DFID, but I think probably there are people in the audience who can really answer on who is likely to fund a long-term project.
If anyone has extra money in the audience, that gentleman would like to talk to you afterwards. And then you can talk to the rest of us. I'm going to ask one, I'm going to exercise my right as chair to ask one quick, it could be a lightning round question. What is the most unanticipated thing you found in doing these projects? Just very briefly. Was there anything that you didn't think you'd find or you weren't looking for that really jumped out at you as a takeaway lesson, or either for good or ill in working on these projects? What surprised you the most?
I think for us, the interest was to help the community health workers support the health system by monitoring the child milestones. And we didn't really expect to get the component of the hidden children, so that is really an important thing. And the fact that after we have also been able to help the community health extension workers develop an app for themselves. So that has been something that was not expected.
Very interesting. How about anybody else? I mean, you may have seen everything, before you went into the field, but was there anything that...
I think that the symbolic value of providing equipment to people as a form of validation for their role. So providing a mobile phone with branding on it that shows its purpose, and seeing how that really had a positive impact on people's sense of purpose in their role and validation, and seeing how the community interacted with them as a result was a really nice thing. And I guess we anticipated it, but the strength of that and the power of that was really quite strong.
Interesting. Sandeep, did you find anything?
Well, I'm not part of the program team, but I can tell you some of the stuff which I found was very counterfactual in terms of the research. Is there are several interventions, and I've been trying to research a lot of them in the Gates Foundation. One thing is becoming very clear that aided learning or going through a frontline health worker is probably working a little bit better than guided communication to the beneficiary, that's for sure. But two things which still surprised me quite a bit, because we do a lot of PSAs or TVCs, if you like, and we thought that, and India has over 500, 600 channels, and we thought that in that clutter, is this really a right thing to use at times? But some of the stuff which has worked so well that people still recall it over 2 years later or a year later, which is incredible, because we never had endorsement from film stars and stuff like that. I mean, it was just a homely atmosphere sort of a thing. So that's proven to be quite a bit of a success. And another thing which I found to be most counterfactual to everything is the level of acceptance where these interventions have had in the older generation. We've had things like listeners clubs and things like that, or SHGs. SHGs, you really can't control who the membership profile is going to be. There could be somebody who's a mother-in-law as well as somebody who's young as a daughter-in-law. And it's the older generation which has really liked it. I mean, they've come across and said that, we've never even had the opportunity like this when we were bearing children. I mean, it's incredible that something like this is happening. We thought that these were going to be the confound, they were going to pose as barriers, but that wasn't the case. In fact, I think most of the interventions I found slightly more impact on the older generation than the younger.
Very interesting. Julia, did you?
I'll speak to something in the Zanzibar program, which is related to this idea of kind of increasing self-efficacy and kind of the CHW becoming empowered and gaining respect. And so as we ran into these cultural barriers, which were also kind of a surprise, not completely. I mean, we didn't think we just suddenly get 100% facility delivery from 30% in these areas. But to find that self-efficacy led these people to develop their own creative solutions to supplement our program, which admittedly at the beginning was a bit narrow. I mean, we didn't think about holding community meetings and we kind of thought, oh, well, the woman decides if she goes to the health facility. And they really were the ones that created, the approach of more inclusive counseling and including the husband. We always had the permission form, but that's not enough. So they humanize that. And they actually hold their own, on their own, with no additional incentive, their own, meetings and their own outreach, in difficult places where there's a high resistance to going to the facility, and they took that on themselves. And I think it was a result of that kind of increased self-efficacy, confidence in their own knowledge.
Thank you all. Regrettably, I'm conscious of I want to end on time because I know it's been a long day for everyone, and we'll start again early tomorrow morning. I want to thank our panelists who were terrific, so thank you very much.